Kia ora and welcome to No ME, the podcast video series where guest speakers talk about pressing issues surrounding myalgic encephalomyelitis, chronic fatigue syndrome, and long COVID. Join researchers, clinicians, and patient advocates as we take a deep dive into the most recent evidence-based information so that you too can know ME. ANZMES does not benefit from or receive any funds from any courses or products mentioned in this podcast episode. ANZMES does not provide medical advice directly to patients. Please always seek professional medical advice. This podcast is intended for health professionals seeking information on how to help patients with these conditions. In today's episode, we will discuss both professional and lived experience with myalgic encephalomyelitis, long COVID, dysautonomia, and mast cell activation syndrome with Dr. Asad Khan, who joins us here today. Thank you for joining me here today, Asad. I'd love to chat with you today about both your personal and your professional experience with the conditions, ME, CFS, long COVID, and also dysautonomia and mast cell activation syndrome. So would you like to just tell us, firstly, just a little bit about yourself?
Sure. Well, first of all, Fiona, thank you very much for the opportunity. Kia ora to everybody listening from New Zealand. I am a respiratory consultant, have been one since 2009. I've had various jobs in the UK and also in New Zealand. I used to work at Waikato Hospital between 2014 and 2018 and have very fond memories of there. Our daughter was actually born there and has a Maori name. Anyway, we returned to the UK in 2018, and my specialty within respiratory is sleep. People who have sleep disorders, which you know is quite pertinent perhaps to this discussion. I also have an interest in junior doctor well-being and civility in the workplace. So being kind to each other is a big passion of mine, because we see a lot of bullying and a lot of poor behavior, which is totally unnecessary and unacceptable. So I've done all I have been able to over the years to challenge that. And I was very frontline in the pandemic throughout the first and the second waves. Being respiratory at the time, it was thought that this was a respiratory virus, which now we know it is not. I mean, it certainly does spread through aerosol into your upper airway, but from thereafter, it's actually a blood disease. So I worked on the acute COVID wards. We were all put on shifts, no matter what seniority we had. Managed to escape unscathed through the first peak. But through the second peak, first half was okay. Again, working on the acute respiratory COVID wards, we didn't have PPE. I mean, we did have surgical masks, but according to the health and safety executive in the UK, they're actually not PPE. But so there is this myth that we were provided with protection when we went. And then we had a plastic apron and plastic gloves. So against an airborne virus, that is not really any protection whatsoever, because humans are aerosol generating creatures. We spread the virus when we talk, when we laugh, when we sing. And I was surrounded by 28 people coughing and spluttering all over me. For when I became ill, an entire week, obviously at that time supporting the nursing staff, supporting the junior doctors. Those were also the days of FaceTime goodbye. So we were having to be family and friends with the patients as well. So it was a stressful time, but I viewed it as, and this is without sounding too cliched, I viewed it as the day we trained for. And, you know, it was just part of the course. Didn't see ourselves as soldiers or heroes or anything, but, you know, this was our job and we were doing it to the best of our ability. I just wish we had had the right protection. And the irony is that we did have it, but because this myth was peddled that this is spread by droplets, we weren't given it, apart from very special circumstances, such as when people were being ventilated through a tight face mask, something people might have heard of called CPAP or NIV. So I developed, I remember the date, I developed symptoms on the 21st of November 2020, and life has not been the same since. I tested positive by PCR. I then promptly went on to share it with my wife, and subsequently my 2 children fell ill as well. They all recovered. I never did. My initial illness was what you might call mild, even though I think mild is a misnomer. Lots of people didn't go to hospital because they were told to stay away and only to attend if they were dying. And I felt dreadful, but I wasn't dying. So I spent a month at home. And at the end, I was still really fatigued, off my food, but you know, again, out of a sense of duty and also perhaps due to some pressure, went back to work. And that was Christmas weekend. And I wish I had known the value of rest at that point. And at that point, I didn't know there was such a thing as long COVID. I knew that there was a disease called ME. I knew it was organic because a really dear friend's daughter had ME. But even then, they used to call it chronic fatigue syndrome, which now I know is a name that's actually quite offensive and does a disservice to the condition. And I knew that exercise didn't help in that condition. So, but that was the level of my knowledge. It kind of stopped there, but I understand that that's actually probably more than most. And so, so anyway, through no effort on my own part, it was just that I happened to know this person, and within 3 days of going back to work, which was basically desk work, a couple of hours a day, just looking at letters and results, it was as if a bomb had exploded inside my body. I developed rashes, which covered my entire face and neck. They were so distressing that they made me want to go and lie in the snow just for a bit of relief. I remember that symptom did not respond to antihistamines or steroids, and it was the first time I felt in my life, I cannot carry on like this. If this happens, and this keeps going on for another day, I will take my own life, because it was just unbearable. I also had difficulties with cognition, so I got really confused, memory problems, didn't know who I was, where I was, issues with urination, so really stinging and burning, chest pain, palpitations. Cut a long story short, ended up in ED, my own ED, ironically, 7 minutes away from my house, and attended there, I think, a total of 3 times. And people were nice, probably because of who I was, but really didn't have anything to offer. Typically, you go to ED, they do some baseline tests, they all come back normal, and annoyingly, by the time you go there, your heart rate has settled down. And they say, well, you know, really sorry, there doesn't seem to be anything seriously wrong, off you go. Maybe you're anxious. At one point, I started believing it. But then in hindsight, it was just stupid, because, you know, how can you anxious up a rash or burning urine? I mean, it's just nonsense. But there didn't seem to be any explanation at the time. Long COVID had been reported, but, you know, I was too busy keeping up with the acute stuff to pay any attention to that. Then I discovered a Facebook group of doctors in the UK with long COVID, because I wasn't really getting anywhere with medical professionals. My GP is amazing; she's very supportive, but again, they weren't being told very much, and you know, she was really being guided by me. So I went to this Facebook group and I said, well, this is what's happened to me. And they went, you have POTS and you have muscle activation syndrome, and you probably have a background of hypermobility. And it's quite clear that before you became ill, you were in sympathetic overdrive. Now, all of this will be no news to anybody who's got ME, because you're familiar with this sort of lingo, but it was news to me. I knew what POTS was, but didn't know, you know, how to diagnose it or how to treat it. And the rest I'd never heard of. So it was great that they told me what test to ask for and what treatment I needed. And then began the journey of navigating the alleyways of the NHS and realizing, actually, for people with a disease that doesn't fit into a nice little box, there is actually nothing. I mean, the NHS is a great gift. It's wonderful for acute problems. You know, you could need a liver transplant acutely, and you could be living on the streets and you'll get it. But for anything that is chronic and complex, it really does fall short. So we have this thing within medicine where it's all about to reassure and discharge rather than think, stop, investigate, be curious. So somebody comes in with chest pain, for example, you've got a couple of things on your checklist, such as, is this a heart attack? Is this a pulmonary embolism? You decide it's not that. Once it's not that, it doesn't really matter. And that's the harsh reality I learned. And I was groomed in that reality, unfortunately. Really, it should be about, well, okay, it's not these things, but the patient's still suffering. Let's remain curious. Let's see what else it could be. Maybe we don't know enough about this. Maybe there isn't a lot of randomized controlled trial evidence about treatments, but there may be some treatments that could help symptomatically. Anyway, it fell to me then to find private doctors who would treat the conditions I was diagnosing in myself. Now, I am very aware of my privilege here, that I was able to do this. But for people who don't have that sort of background, it must be so isolating and so lonely. It was a case of finding the right people, telling them what the plan was, and then hoping that they would listen and implement it, which they did, to be fair, mostly. But then I was having to pay out of my pocket for this, and the GP would follow through, which was great of her. But I had my share of gaslighting, make no mistake. I was told by one doctor that my rash was anxiety related. I was told that I was perhaps over-perceiving my symptoms. When I volunteered that a certain drug had helped me, I was told that there was no evidence for that. And I was like, well, no, I'm the evidence. I'm telling you, this is the mechanism by which it works. This has really made a difference. We're talking about ketotifen here. So the arrogance and the ignorance was quite spectacular, actually. And it made me really reflect on, perhaps some of my own past practices where I thought, have I missed a young woman with POTS and labeled her anxious because I didn't bother to stand her up before walking her out the door? It was very sobering and very humbling to think that might have been the case. I just continued to get worse and worse, however, and by September 2021, I was in a darkened room on my own, and sort of blindfolded, earplugs, the picture. Could not tolerate any light, any sound, any food. I had gastroparesis. I would vomit the moment I lifted my head. And it was interesting, on reflection, I can laugh about this. It was a case of choosing between two kinds of nausea. So you lifted your head and you got the POTS nausea. And then you thought, right, I'll relieve this by lying down, because in POTS, all you want to do is lie down.
Yes.
And then the gastroparesis nausea would kick in, and then I'd be tasting food from 2 days ago. Sorry to be so explicit. Like, okay, which of these is more preferable? And that was my day. But I learned how to pace. Again, I'm really grateful to the ME community here. And pacing for me was basically every 15 minutes, change position, do some breath work, coherence breathing. And that would somehow dampen the sympathetic drive a little bit and, make things a little bearable. My PEM was insomnia and nausea, which is a delightful combination, obviously. And we all know that to recover from PEM or PESC, you need to sleep. Sleep never came. I remember 3 weeks without sleep, no exaggeration. And I remember the kids were in the room once. It was just like, there's something in the room that is just making me sick. And if somebody had told me this before becoming ill, I would have said, you're crazy, like nothing like this can ever happen. But it was actually neuropathic pain I was experiencing. And I actually asked them to leave because it was their presence. Just that was so consuming of energy that it just made me really ill. And it was then that I got a call from Germany, from Dr. Beate Jäger, who performs HELP-apheresis, which is a blood washing technique. And she had heard about my case through a friend who'd had the same procedure. she managed to get me across. That was a nightmare. It was an hour's flight. Don't know how I made it.
Imagine.
Yeah, I mean, I would never have thought of an hour's flight being anything substantial beforehand. And she took one look at me on the day of the appointment, and I was due to have the apheresis the next day. And she said, "You're having it now because you're really sick." And then I realized that I was full of clots. The clots were so severe that they were blocking the machine at 2 liters washout. Normally, the machine can wash 3.5, 4 liters. But in my case, just couldn't get there. Then I was put on anticoagulation, and that helped matters, and things started to improve. I noticed some quite distinct improvements in the POTS, in particular in the cognition, in the chest pain. So this is September 2021, and by December, I was able to walk short distances, and I was actually able to think clearly, although not fully clearly, and I was able to have a conversation with people. Throughout this time, I managed to still do some advocacy work. So I appeared on YouTube with my friend Jess Bettinger, and had also been involved in the local long COVID services setup, which usually comprised of me saying, well, this is what you need to do. And then they'd go, oh no, we're going to do rehab or CBT instead. So I had to leave that. And that hasn't changed in the UK, unfortunately. So yeah, things were pretty good in December, but then on the way back to the UK, or on arrival, I got reinfected. And then it was just reinfection after reinfection. And I've had four in total, 4 reinfections between January 2022 and August 2022. In between, I had a vaccine injury as well. So in February 21, I forgot to mention, soon after becoming sick, we were all told that we had to get the vaccine because we need to come back to work, and obviously vaccines can do no harm, can they? So it was stupid in hindsight. I was still sick. I had no business getting a vaccine. You wouldn't vaccinate a sick child. I mean, vaccines are great, obviously, but they're still a drug. They can cause problems. And this one,
not when the body's under so much stress, so much
absolutely
is going on. Yeah,
and you'd think that a medical mind would know better, but we were just swept up in this whole narrative of, well, you're going to get reinfected if you come back to work, so you need to get the vaccine. Well, now we know it doesn't stop you getting reinfected in the first place. So yeah, things got a lot worse, and I had a few new symptoms as well. The POTS in particular did deteriorate further to the point where I needed 6 pillows to just underneath my heels to keep circulation to the head going. Yeah. So I have not had a further one. My advice to people now is, well, if you've had a vaccine side effect, then it's probably wise not to get the same vaccine again. Also, if you are acutely ill, then really think very carefully about getting it, because it's probably not the right time. That's all I'm allowed to say publicly. So these reinfections really, took it out of me, and not as bad as I was back in September 2021. I would be speaking to you, but I am still quite limited again. As in, I haven't been able to get back to work. My sleep's still terrible. Like, I do sleep, but there's no slow wave sleep, no deep sleep whatsoever. You wake up feeling awful. I've got documented cognitive impairments. I might sound quite fluent, but we know that that's episodic. And, I have issues with short-term memory. I have issues with dual attention. So, I can't pay attention to more than one thing at once, which for a doctor is no good. And still have MCAS, urticaria, still on immunosuppression for that, still on anticoagulation. My pill box is, quite something. And I think all it does is just keeps me at a level. It doesn't really fix anything, but keeps me at a level where I can function.
It's symptom management, isn't it? Rather than getting to the root cause and fixing the problem. Yeah. Absolutely.
And, I'm very grateful to the doctors who have treated me and, have listened at least and validated and tried things that, perhaps were a bit unorthodox. But I think that's where your clinical acumen comes into play, because when there isn't that evidence, then the person in front of you is still sick. And there's very little evidence that doing nothing is any good when somebody is so sick. You know, when their heart rate's going at 150, just saying, oh, it'll just go away is not good enough.
No.
You can still offer symptomatic treatment. And this is my big bugbear now. You know, why don't doctors and patients have a conversation that is informed, weighs up the risks and benefits, and involves a trial of treatment, you know, 3 weeks, 4 weeks, and then you just agree that these are the potential risks, and then, you know, let's review it at the end of 4 weeks, and if it works, continue. If it doesn't, well, then we try something else. We seem to have lost that ability to think. So I'm not in work still, like I said, and I just have like 2-3 hours in the day when I can do stuff. And most of that is taken up by sort of admin around the sickness, which will be familiar to the listeners. Also, things have sort of fallen apart for me personally as well. So I have been living in various spare rooms for the past 2 years. And so, you know, that's another challenge. And I'm going to stop being paid as well at the end of next month. So there's a few issues ahead, but I am really trying very hard to build a future where I can be of use to this community, because I see this as my calling. And I see this as an area where the population is underserved, and really you know, there's a lot of scope here for helping people with simple things. I just need to get a little bit better to be able to do that. And then I think, you know, I'll be able to feel purposeful again. So anyway, that was it in a nutshell.
And that's so important when we are so ill, is to have that purpose and that meaning. And if we can contribute in our own, even if it's a small way, you know, that we feel that we're actually still contributing to society, even if it's from a home or even from our bed sometimes. It's so important to have that. And that's part of why I'm in this role as well, because I haven't been able to work for 15 years. But I can try to make the difference through these charitable organizations. I did want to go back to something I just realized that we haven't really covered for our health professionals, is about the micro-clots in long COVID. And obviously you were talking about how anticoagulation worked for you and actually helped control some of the POT symptoms as well. Do you want to just touch a little bit on what we know now is going on with micro-clots in long COVID?
Sure. So micro-clotting is nothing new. It's actually not unique to long COVID. It's been known in other diseases as well, such as type 2 diabetes and Alzheimer's and Parkinson's, mainly through the work of a group in Stellenbosch in South Africa. Professor Respiratory and a collaborator, Professor Douglas Kell in Liverpool in the UK. And what they discovered at the beginning of the pandemic, actually, was that people with acute COVID had these micro-clots. And it's a very simple technique. It uses fluorescence microscopy, which is a microscope using a special dye, and these clots just light up bright green. And parallel to this, a clinician also in South Africa called Dr. Jaco Laucher figured that this was a disease of clotting and started treating people with acute COVID with anticoagulation, and they started getting better. And these are people who otherwise probably would have gone on to deteriorate, go to ICU. And those two then got collaborating, and then Ricia started getting samples from patients who just weren't getting better after their acute episode, what we now know as long COVID, and found similar clotting abnormalities in the blood of those patients. So they were micro-clots and hyperactivated platelets. So platelets are a kind of blood cell that helps with clotting. It's one of the initiators of clotting, and only quite small, but these were sort of massive and very angry looking, pink and green monsters. And these microclots were different from microclots in other diseases in that they're much more numerous, much bigger, and actually don't break down with the use of an enzyme called trypsin. So the diabetes ones, for example, they dissolve. So it figured that in our bodies, these clots are circulating, they're not being broken down. And as a result of that, the blood supply to different organs is being compromised. So because the clots are causing a blockage, or at least a partial blockage, your whole body is starved of oxygen and nutrients. And that is a perfect explanation for the symptoms of long COVID. I'm not saying it's the only explanation, but certainly it is an explanation that does make sense. And I didn't know any of this until I actually had clots discovered in myself. And then I obviously did a rewind through the history and realized that, you know, this was something that had been known. I went on to triple anticoagulation, which is 2 drugs to address the platelets and 1 drug to address the clotting itself, under the supervision of Dr. Laubscher himself. And have had several courses of this, and have tried to come off, but then either due to reinfection or due to the fact that there is some other persistent thing driving the clotting, which hasn't been dealt with, I've had to more or less stay on it. However, I do know of people who, through this therapy, have more or less had a restoration of health to normal, and it seems to be mainly people who got treated early. And it sort of makes sense that if you get in early, clear the clotting, clear the platelet hyperactivation, then the body, you know, it's a wonderful thing. It tries to restore things to normality. Its tendency is always to try and heal. So the body will then take care of, you know, any sort of viral persistence, if there is that, or autoimmune phenomena, if those are developing. But obviously, the longer you leave things, the more permanent tissue damage you are likely to get due to reduced circulation, the more likely you are to develop autoimmune phenomena that then don't go away. The more likely the virus is, or viruses are, to find their way into areas of the body where the immune system can't reach, such as, you know, the eyes, the nervous system, the testicles, for example. So in summary, that is where we are at the moment with microclot science and treatment. There hasn't been a randomized controlled trial yet, because the people who are interested in this seem to be people who are just busy trying to do their job and help people. It is an unorthodox concept, because the thought of 3 drugs to treat clotting, you know, immediately raises alarm bells. And obviously, you know, these drugs should be given under supervision, very cautiously, with a full discussion of the risks and benefits, bearing in mind there haven't been any randomized studies on this. However, one thing worth bearing in mind is that people with long COVID, we're in a hypercoagulable state, so our clotting is not normal like that of other people. So what is happening here is we're just trying to make the blood coagulation normal, rather than make the blood more runny and make you more likely to bleed, if you know what I mean. Yeah, that's where we are. The other thing is that the whole idea of these clots and platelets, it isn't widely accepted, and I think that might have something to do with prejudice, because I see no other explanation. You've got an African woman who's discovered this. I suspect that if this was discovered in London or, you know, Harvard or Yale, then the response would have been quite different, because recently there's been a spate of papers trying to, you know, really discredit this finding. And you wonder how much time these people have on their hands, you know, doing supposed research and reviews just to oppose a finding that has been replicated over and over again. And nobody's saying this is the full story, but it's a very important part of it. And the patients who have benefited are the evidence. Not one patient where these clots have been looked for, who has long COVID symptoms, has come back negative for them. Everybody's got them.
Mm. Yeah, that's really interesting. I mean, yeah, we seem to find that happens in the ME community as well, with people trying to actively discredit the NICE guidelines, despite showing that the evidence is suggesting that, graded exercise therapy, cognitive behavioral therapy do not work for ME, because one, it's not a psychological disease, and two, because of the post-exertional malaise that
Absolutely. And I think, it's just causing harm. It's not just a matter of making an honest mistake. People have been disabled and, dare I say, have lost their lives because of this malpractice. And we don't have accurate figures on this because these patients are never seen. But this is criminal. And also, we have to go back to the basic principle of, if the patient in front of you is saying, this is not helping, this is actually making me worse, then forget the guideline. Listen to the person in front of you, and just respond to the situation. It doesn't take a genius.
Because we live with the illness day in, day out, minute by minute. We know our bodies and we know what works and what isn't working for us. I do think it's very important for that patient-doctor relationship to be collaborative, and for health professionals to be listening to their patients and, taking their word for it that they do understand what's going on in their own bodies.
They understand way more than most doctors do, because obviously this has become our lives, and we have to be our own advocates, which is really hard when you're starved of energy and you've got cognitive issues, and you're on a 10% battery if you're lucky. Whereas I understand that doctors can't keep up to date with everything, but they should remain open-minded and curious. And now there is no excuse whatsoever. I mean, there never was for not listening, but for not having the knowledge when, I've lost count now, but I think the last figure I saw for long COVID itself was 147 million or something in that region worldwide, of whom, a huge proportion are going to have ME, because at the end of the day, it's a virus. And we have a very good, if not perfect, guideline now. It's all there.
Yep, the evidence is there. And this is part of why we're doing this podcast, is because we know how overworked and understaffed health professionals are. And particularly with this pandemic, they're just inundated with sick people, more than ever. And so this is part of why we're doing this, is that if they can have bite-sized chunks of information that is, giving them the vital, pertinent information that they need, that they can help their patients, then, all the better for our communities. When did you know that you sort of weren't recovering from long COVID and it might actually be transitioning through into ME?
Before it happened, because obviously I went down a rabbit hole, trying to find out as much for myself, and became very aware of the importance of rest and of the phenomenon of PESC, post-exertional symptom exacerbation.
Yes.
And in the early months, I didn't have that. I had fatigue, and exertion would make me worse, but there wasn't a delay. So just resting after the exertion, like you would after a workout, for example, would resolve matters. But I knew that unless something changed dramatically in my body towards improvement, then this was a likely possibility. And there were lots of people around me to whom this was happening. And then it did. It was almost sort of unnoticeable, in that I just realized that for no reason some nights I was not sleeping, and having this crippling nausea, and accompanied by a tachycardia, worsening of the urticaria. And I was like, well, wasn't really doing anything for that. And then I then started to make the link with what had happened sort of 36 hours previously, which was sort of my delay.
Mhm.
And then I realized that this had happened. I've never really had an issue with that, never really had a stigma about this, because I think AI was prepared, and I just thought, well, it's an organic illness at the end of the day. It is what it is. And it was almost like part of me was relieved that I had at least something that doctors had heard of at least,
Mhm.
and weren't saying there is no such thing.
Yes.
We do get that a lot with long COVID still. I'm not saying it doesn't happen with ME, but probably even if people have the wrong view, it's unlikely that they will say there isn't such a thing.
Mhm.
And I also, because I thought that this was an opportunity to learn from the decades of research, of which there is a lot. I mean, people say we don't know anything about ME, we don't know anything about long COVID. I mean, these are very well researched conditions. Treatments haven't been researched as much, that's true. But in terms of the physiological and metabolic abnormalities, there is tons there. We don't have all the answers, but then you don't need all the answers to believe people, and you don't need all the answers to start treating them either. So I realized very early on also that it was really important to align both the communities, because otherwise what would happen is we in the long COVID community would be preyed upon by the same people who had abused the ME community if we weren't careful. And that is happening. It's been happening since day one. So we needed to use that knowledge, that exercise, pushing beyond the anaerobic threshold, CBT. These things are not going to be helpful, certainly GET can, well, in most cases, it's harmful. And if it isn't harmful, then one has to question the diagnosis. Also because I just felt that it was important not to replicate experiments that had already been done. And sadly, a lot of time and money has been wasted on that, on studies of exercise, for example, and studies of looking at, for example, cytokines. I mean, I'm sure they're a signal, I'm sure they mean something, but they don't really offer a therapeutic target.
No.
We've known that in ME for a while. Yet we see the same stuff being reported as, oh my God, look at this, it's so interesting, it's really novel. Yeah, it's not. So we've lost time, and we have lost people, unfortunately. And we've lost money, because now the funding's dried up for long COVID research, and this is again something I think people don't realize, that this is not a priority anymore for governments, because if they were to take this seriously and say, okay, we have this mass disabling event that has wrecked this generation, and this is why planes aren't flying, because they don't have crews. This is why the bidmen don't turn up. This is why, your bank tellers off. Admitting that that is the problem would then mean needing to do something about it, which would obviously mean investment in biomedical research. But more importantly, it would mean stopping people getting the illness in the first place. And how do you do that? Well, you ventilate indoor spaces, and where appropriate, you reintroduce masking. Well, no government wants to go there, because that is just too politically inconvenient. And not only that, that would involve an admission that people got it wrong, that governments from the beginning didn't do the right things. Teaching staff in the UK have outstripped healthcare workers in terms of their infection risk. So why is that? And is that inevitable? Of course not. If we ventilated classrooms, then probably wouldn't have seen the same rate of teaching staff getting the illness, getting long COVID, and also children. I mean, that is something that gets forgotten in all of this. The children with long COVID, who can't even advocate for themselves, who are being once again psychologized, who I have heard, and this is unconfirmed, but I have heard in some cases being asked to crawl on the floor by the healthcare professionals because they really should be able to walk, and this is not organic. And families under threat of their children being taken away. I mean, this is like the 80s. Have we learned nothing? I mean, honestly, I cannot believe the degree of regression here. So anyway, I forgot what the point was here, but I guess it was about learning from the ME community, and it's clear that we haven't.
Yeah. And as we're on the subject of long COVID kids, you work in that advocacy space. Do you want to tell us a little bit about that, what you've been doing?
Yes. So I am a member of Doctors with ME. I'm what they call an associate, and I'm also a champion for long COVID kids. So I don't know what the exact figures are last count for children affected with long COVID, but it's well above 60,000 at the moment in the UK. And the reason we need to pay attention to kids is because at the beginning we were told that kids don't get COVID, full stop. Then we were told that they don't transmit it. Then we were told that if they got it, it was mild. Then we were told that they didn't get long COVID. Well, I mean, all of those things have been disproved. But more so in the kids arena, there seems to be a particular group of doctors who have made it their mission to minimize the risk of this virus to children. Despite all the evidence and despite all the families saying, look, since our kid got the virus, they just haven't been right. They can't go back to school. They're fatigued, whatever. I mean, there are some differences with children that seem to get more sort of neurological type presentations. Otherwise, the disease has a lot of similarities with that in adults.
Yeah.
And there are children with full-blown ME as well as a result of long COVID. The full picture, I know personally children who are confined to bed, confined to rooms, total stimulus hypersensitivity and intolerance. And for them to access even basic care, and I'm talking the very basic sort of being believed, getting a diagnosis is a struggle, even in tertiary centers that should know better. So in long COVID kids, our job is to keep giving the message that kids do get this disease. It can be quite serious. It can be prevented if we, first of all, ventilate the classrooms, and secondly, tortoise versus hare. So if a kid gets the illness, and obviously there's no testing nowadays, so one has to assume that if they get a respiratory virus, then it could be COVID, that they rest, and that what is prioritized is recovery rather than education. So kids are incredibly resilient, incredibly intelligent, more than we give them credit for. They will pick up what they've missed, in school, if you allow them to recover. Something I haven't divulged in public yet, which I will now. My son has the illness. He is 12, and he got a virus in March, and obviously there was no testing then. He had one lateral flow test, which was negative, but we know that lateral flows, particularly in children, women, those of a younger age group, and with the new variants, aren't as accurate, and sometimes you have to keep testing, and it may turn positive later on. And then I didn't have access to him for some time, and then when I did, thought, this kid is not right. He's grey, he's drowsy, he's not able to stand up. And then I picked up that he had POTS. Not a difficult diagnosis to make. You just need to stand them up. And again, I knew what to do because I've been through this myself and had the support of other healthcare professionals whose kids had long COVID, most notably Dr. Benita Kane, good friend of mine, and was able to get him the right medical attention in a timely fashion. He's a lot better now. Still not fully healed though. I mean, still has spots and still has to face, but can do a lot more and is able to go to school. And I think this is an example of why this is important, because we were able to institute the right measures, the right treatment, the rest, the prioritization of recovery over schooling. I don't know if you have this madness about attendance in New Zealand, but it wasn't as bad when I was there. But here, if you have one day off and you can't explain it through an illness that the school doesn't understand, you can get fined here. And there's a lot of pressure, and I think it comes down to ableism. And it also comes down to, what as a society we value. We value people based on their output, what they achieve, what they produce, rather than who they are as individuals and people, how they treat other people. Sorry, I'm digressing a bit here, but I think this is important. And it's a battle, fighting that narrative and going, actually, you know what? I know what is right for my kid. I have the knowledge here. I have the experience. Everything else can wait. To be fair to his school, they've actually taken this on board. But I know other cases where it hasn't been the case, and the families have had social services descend on them because they're thought to be depriving the kids of an education and acting against their well-being. And imagine being accused of that as a parent.
Yes. And obviously, your son is a case in point of the early intervention, putting in the right strategies, and he is on his road to recovery. So you've proved the point that doing it a certain way actually helps them in the long term.
Yeah, and I know that he's at risk of further post-viral illness because he's hypermobile and he has ADHD, and obviously these are known associations. But at least I know now that if he gets another virus, he needs to rest, and he'll learn how to manage it himself as well. But I think this is why this advocacy is so important, and what you're doing is so important.
So I've just thought we might just touch on a little bit about the hospital setting. It's sort of a bit of a segue here, but do you have advice based on your experience with respiratory medicine for people with long COVID? We've seemed to have seen that there's some disordered breathing that starts to occur. Do you have advice for people with long COVID or with health professionals for their patients on what they can do?
Yeah, good question, Fiona. I think this is a really key area. There's the whole area of breathing disturbance in long COVID, or indeed, in patients with ME, because sometimes the etiology can be quite similar, is complex. It's not just one thing. So you'd obviously want to go through your usual checklist, make sure that they don't have something that isn't necessarily due to their long COVID. So, is it their asthma if they've got that? Have they developed asthma? Is it a pneumothorax? Is it a pneumonia? Those things have a standard way of being diagnosed, and it's really important to keep an open mind and make sure that it's not something like that, because we do get other illnesses as well. You won't want to miss a lung cancer in somebody just because you're going down this post-viral route all the time. Having said that, clearly there's a problem with clotting, and it's important to make sure that we're not missing a pulmonary embolism or sort of clot on the lung. Now, there's a way to diagnose this. You go through an algorithm, you do this blood test called a D-dimer, you work out whether there are risk factors for clots, and having had COVID, in my mind, and there's plenty of evidence now, puts you at increased risk of pulmonary embolism, heart attack, strokes, all sort of diseases of clotting. So the evidence for that is there. So your index of suspicion should be high. So that even if the D-dimer is negative, you should be thinking more carefully about pulmonary embolism. the first-line test is usually something called a CT pulmonary angiogram, a special kind of CT scan. But bear in mind, this is only going to pick up the larger central blood clots. If that's negative and the patient still has the relevant symptoms, then it's a case of doing something called a VQ scan, or ventilation perfusion scan. And there have been many cases where patients had a negative CT pulmonary angiogram, but had a positive VQ scan. There can also be clues in the lung function testing. There's something called DLCO, which measures how well the gases travel between the blood and the lungs. And if that's low, that can suggest that there is an issue with clotting in the blood vessels of the lung. But the thing is that you can actually have these tests all normal and still have clotting issues. Because if the issue is micro-clotting that is moving through the blood vessels in the lungs, the symptoms can fluctuate and all of these tests can be normal. And then you're in very tricky territory. I mean, how do you diagnose that? And how do you treat that? And I think it does then boils down to the importance of finding rapid diagnostics for micro-clots, which in collaboration with Ricia and Jaco, and I've ended up being their collaborator through all of this, we have developed using flow cytometry. It's in preprint, but it's due to be published soon. Hopefully that will enable easier detection and also treatments for this. Having said that, apart from clotting, a couple of other explanations for breathing difficulty, dysautonomia itself. So, the vagus nerve, if it is not functioning properly, which we know is very common, if not universal, in people with post-viral illness, it won't be regulating your breathing properly. So you can have these episodes of what looks like disordered breathing, very rapid sort of shallow breathing, and then followed by periods where it's sort of more regulated. So treating the POTS, treating the dysautonomia itself, and then it's just down to sort of basic measures, fluid, salt, compression, drugs to slow the heart rate down, and ancillary things that the patient can do, such as vagus nerve stimulation if they have access to a device.
TENS machine.
And, yeah, TENS machines can be helpful. I mean, they're not licensed for this use, but on my, I have used them and I found them quite effective. And on my link tree at Dr. Asad Khan, all sort of, spelt out fully. You can find links to how to use a TENS machine to treat dysautonomia. And also something called coherence breathing, which you can look up on YouTube, which is a breathing exercise. Now, and I know a lot of people get really twitched when I mention meditation or sort of breath work or mindfulness or journaling. Now, these aren't cures, and these obviously are not pills either, but they are still treatments. They're symptomatic treatments. In the same way, you can't give a pill to fix a broken limb or a sprained ankle, and what you need is a plaster cast or physiotherapy. I call these things physiotherapy for the nervous system.
It's dampening down the sympathetic nervous system, isn't it?
Yeah, absolutely. So these can be really powerful, particularly breath work. I found amazing. You have to do it consistently, and you have to do it every day. But coherence breathing is very simple to do. You can just look it up on YouTube. And that can really help with the symptoms. But patients don't know this, so it's sometimes about signposting them to these resources. A support group can be great for this. Finally, with the breathing itself, a mast cell activation syndrome can obviously trigger issues with breathing through the development of asthma itself, and usage of antihistamines, sometimes in higher doses than licensed, and other drugs like leukotriene antagonists and mast cell stabilizers can be quite helpful. Even like a trial of a steroid inhaler. So those are sort of, most of the areas I think we've covered breathing there.
Mm-hmm. And obviously you have expertise with sleep, and you mentioned yourself where you were having bouts of insomnia. Do you have any tips for people, advice for health professionals and patients themselves about good sleep hygiene for ME as well as long COVID?
Yeah, so sleep is a major issue. I was really extreme. Okay, so not everybody's going to be like this with sleep, but a number of things can help. Now, sleep hygiene has become a bit of a dirty word in our community, and there is this sort of, well, sleep when you are able to and don't worry about timing. I think that's okay if that's all you can do. But if you are a little better and you are able to have some kind of routine, then I think that exposure to daylight can help regulate your circadian rhythm a bit more. And that is important because the body needs to understand when it's night and when it's day.
Exactly. Melatonin release.
So if you're up and you can expose yourself to daylight, doesn't have to be bright sunlight, then do that. So 15, 20 minutes of that. And simple measures that we all know but seldom practice, such as avoiding screens, an hour and a half before bed, winding down, doing a bit of breath work, doing a bit of meditation, those sorts of things, just to bring you down from that fight or flight and bring you into the right mode for sleep. Yoga nidra can be really, really helpful for some people if you can practice it. But sometimes you need drugs, and there's nothing wrong with that. There's drugs for sleep initiation, and there's drugs for sleep maintenance. Now, we have a deficiency in melatonin because our guts are ischemic, and a lot of melatonin is made in the gut. So supplementing with melatonin can help people get off to sleep, and sometimes you need larger doses than is usual. People get really worried about melatonin and it's addictive and all this business, but actually we're short of it. So what you're doing is just replacing it.
Yes.
But I would build up from a lower dose. If the issue is sleep maintenance, the patient's waking up after managing to fall asleep, so 3 a.m. long COVID ME time, then again, obviously do all the non-pharmacological stuff, the grounding, the breath work, but sometimes again you need pills. Mirtazapine can be helpful, but it has this issue with weight gain, which for some of us is already a problem. So Mianserin is an alternative that can be helpful, but just be careful. If patients are already on other antidepressants, then you might want to just watch out for interactions there. And the other things are natural remedies, so valerian and passion flower, they can be helpful in sort of sleep initiation and maintenance. And for very, very extreme cases, so I forgot to mention there's a couple of other things. So 5-HTP, tryptophan, but again, these increase serotonin. So if somebody's on an SSRI, then you need to be careful. And that applies to patients as well, because you can't get these over the counter.
Yes, you can.
And with supplements, it's really important to get good quality ones. It's worth, if you can, spending a little bit extra to going to a reputed supplement provider rather than just getting what's on Fishpond or Amazon, where we are. So of course you don't know what's in them necessarily, or in what quantity. And then for the extreme cases, I found something quite helpful called Amanita muscaria, which is a mushroom, which is legal. It's not the same as magic mushrooms, but it has to be treated before you consume it, because it can be toxic. So I would definitely not advocate doing this yourself. I would advocate finding a a practitioner who is able to source them and give you the right instructions about how to treat it before consuming it. But that is the only thing that's worked for me, to be honest.
Well,
And I'm actually
okay.
getting a bit of deep sleep now. Yeah.
Well, that's good. I mean, obviously you've improved quite considerably from the days where you were, basically it sounded like experiencing very severe ME, with
At
the
least severe. Yeah.
the high sensitivities to light, sound, just other people being in the room. Obviously, with our ME community, there are people who get into that severe and very severe category, and then they generally will have the POTS as well, and they're mostly seen in a hospital setting, which can be very traumatic in itself. You know, they will experience pain. So do you have advice for people in a hospital setting when they come across a patient like this as to how they can help them?
So there's actually a document on this, and I can't remember exactly who produced it, but if you look it up, it's called Care of the Severe, Very Severe ME Patient in Hospital Settings. So that is quite valuable. What the key things are really avoiding hospitalization if you can, firstly. You know, can this thing be done at home? And this is one of the cases, and I know that GPs rarely do home visits now, but this is one of the cases where it is totally justified. In fact, you know, it would be wrong not to do that if a patient with severe or very severe ME needs medical attention. And just because they haven't been seen for years doesn't mean that they're not still ill. The likelihood is that the family are caring for them because the health system has let them down. And there may be times when, you know, it's unavoidable. You know, they have to have a procedure, for example. They have to have a PICC line fitted or you know, a PEG tube. And what do you do then? So, you know, making sure that the ambulance crew are aware of keeping the environment in the ambulance low stimulus, so darker, being very gentle with movements and transferring, because that can be extremely distressing. You know, driving at a slow pace, and listening to the family. You know, usually it's the parents or other relatives. If they say, well, actually, no, this might help, or please can you avoid this, because use that resource. They've done it for years. They know how to manage the situation. If you're in hospital, then again, avoiding sort of open bays, noisy environments, making sure that it is a side room. I mean, I think that's the minimum. Planning the admission, not just sort of, you know, rocking up to the acute medical unit and waiting for a bed in the corridor. That is not acceptable. Making sure that there is a side room available, making sure that, you know, the lights are down, the blinds are drawn, that you only go into the room if it's absolutely necessary. You plan those visits into the room. You have a specific time for it, according to when the patient might be at their best, and only whoever needs to go in goes in. It's not taking your whole sort of troop of medical students and registrars with you. And actually, you know, using other ways of communicating. Baby monitors are great for communicating with the patients and families inside rooms. So there are ways around this. And then ending the admission as soon as you can. So once whatever needs to be done is done, then getting them out of hospital swiftly, but again, gently and safely. So those are sort of, you know, just general tips. It's common sense, but it's amazing how often people get it wrong, and patients end up being traumatized by the experience. Never want to go in again, even when they really need to go in.
Exactly. No, that's excellent advice. I mean, in hospitals, that, you know, they're busy and it's the status quo really. So having just little tidbits of what they need to do for these patients is important. So thank you for that. I'm conscious of the time and how draining it is actually to be having this conversation. So I just thought we've finished up. Is there anything particularly that you want to say to health professionals that you'd like them to know about these conditions?
I think the number one thing is believe your patient. There is no secondary gain here. We, through this illness, you know, we've lost our independence. We've lost our ability to work. In the vast majority of cases, we've had to come out of education. We've lost family members. There is no financial incentive here either. I mean, there is this myth propagated that, oh, well, you know, we get benefits. Well, the benefit system is extremely hard in the UK. Navigating that is a job in itself, and I'm sure it's no different in the rest of the world. So actually, we're just about making ends meet, and in some cases, not even doing that. Nobody would choose to be this way. Nobody would. I'm yet to meet anybody with a chronic illness who wouldn't rather be well. So bear that in mind and believe your patient, first of all. If they're displaying psychological distress, that is likely to be a result of the illness, not the cause of it. It's because the symptoms are so intolerable. Thirdly, please don't fall into the trap of we don't know anything about this, or we can't do anything about it, or, you know, time will heal. No, that's not the case anymore. This is 2023. There is a lot known, even though, you know, like any other illness, we don't know everything. And there is a lot we can do. Some of it we've been through in this episode. But, you know, if you treat their mast cell activation syndrome, if you treat their dysautonomia, if you maintain their hydration, if you ensure the right environment for these patients, and if you keep an open mind when they have a new symptom and approach it the way you would in any other patient, then there's a lot you can actually do to make us feel better. And it may not cure the condition, and nobody's expecting that. I mean, you know, at the end of the day, we've lived with this, we understand the illness, but symptomatic relief can make a huge difference. So please don't fall into the trap of diagnostic nihilism or therapeutic doom and gloom. There's guidelines out there. For ME, obviously you have the NICE guidance, but then there are guidance on the specific conditions as well, like MCAS, like CLOTS, loads and loads of really good resources. Some of it's on my Linktree, and the same for long COVID. So there was one that came out of the Patient-Led Research Collaborative, a review, and then we published our own review in Cell Press a few months ago, sort of, you know, which explains the pathophysiology and what you can do. So have a read through those, but also, you know, sometimes just asking the patient what helps. Okay, what have you found useful in this situation, and what doesn't help? That will give you the answers.
That's great. Thank you so much, Namahi. Thank you for joining us today for this episode of No ME. Asad, it's been amazing to hear from you. Your personal journey has not been easy, but you have a wealth of knowledge to offer to us. So thank you for giving us your time today.
It's been an absolute pleasure and a privilege. Kia kaha, and hope we can talk again.